Welcome to Women Mastering Midlife, where we dive deep into the rich complexities of womanhood in our middle years. I'm your host, Victoria Byrd, a pharmacist, certified women's health coach, and your guide on this transformative journey. Whether you're navigating perimenopause, thriving in menopause, or mastering midlife's many transitions, this is your weekly dose of expert guidance, compassionate support, and a judgment-free space to explore it all. Here, we're empowering women to master midlife on their terms, reclaiming our health, our happiness, and our power. Together, we'll rewrite the narrative around this remarkable stage of life, from something to dread into a beautiful, bold transition. I'm so glad you're here. Hey, everybody. Welcome back to another episode of Women Mastering Midlife. Now that we've gotten through a year of podcast episodes, which I cannot believe that I am in my second June on this podcast, I wanted to create an Ask Me Anything episode. So I've been compiling questions from clients, women I meet on the street, women who respond to my newsletters, and just things that come in through the Ask Me Anything form. And so I wanted to use this episode as an opportunity to answer some questions, maybe tell you a little bit about myself and my practice in some of the answers of some of these questions, and get some common misconceptions kind of just cleared away. So I hope you enjoy this episode. It's going to be a mixed bag of tricks. So just buckle up, go for a walk, chill out, do your dishes or laundry, which is typically when I put headphones in my ears, and enjoy. So one of the first questions that I wanted to answer today was, what inspired you to go from pharmacist to menopause health coach? And I think it's an interesting journey that I've been on. It all started with, I became a pharmacist I graduated pharmacy school at what was St. Louis College of Pharmacy. It's now University of Health Sciences and Pharmacy in St. Louis. When I graduated Stillcop in May of 2004, I had already signed on for a retail job with a local pharmacy. I had done retail pharmacy since I was 16. For my 16th birthday, I wanted to get a job. My dad took me around to different places for applications. Eckerd Drug in Atlanta was hiring a cashier specifically for the pharmacy. I applied, I got it, I was hooked. That buzzing dot matrix printer and all the phone lines and the drive-through and meeting new people and connecting with patients and learning about drugs. It was a world I had never heard about. My dad he went to law school and he worked for an insurance company. My mother was a stay-at-home parent, so no science in my family. I didn't even really understand what it would take to get there. So when I graduated from pharmacy school many, many years down the road, I still wanted to do retail. I enjoyed the connection with patients as a community pharmacist. I loved being able to see people on a regular basis, touch base with how they're doing. I did some rotations in a hospital, and it wasn't my jam as much. I'd much rather be talking to people out in the community than talking to physicians and the like on rounds. It just wasn't my thing. I feel like when you start going through your rotations in pharmacy school, you decide if the clinical route or the community route is your jam. And I just loved connection with people. And so I worked for a few years. I worked as a pharmacy manager, supported my husband through his fellowship training and his residency. It was a 5-year residency and a year of fellowship. And then when he was done with his fellowship, our decision was to find a practice in a place that made sense for him, because I would be a stay-at-home parent raising kids and I could make a home anywhere. And I wanted to support him finding a practice that suited him. So, my upbringing, I moved a lot when I was a kid with my dad and my mom. My dad would get jobs, transfers, or new jobs. And I just kind of felt like that was an important part of my family, was that if you're staying home with the kids and there's one primary income provider, making sure that they love their job and they're in a place with people that they love to work with was the number one priority. So I spent many, many years home with the kids. And then it got to be about 2019. Maddie was 10. Abby was 8. And I was looking at, they're in school full time. I'm volunteering. I'm doing all the things at school, but I wanted to do something more with medicine or wellness. And going back into a retail pharmacy with my husband's job being what it is and being the hours that are required of a pharmacist, it's open to close for a pharmacy, holidays, weekends, only a couple weeks vacation. And given that my husband was a private practice physician, he was, he's busy with call and different committees and boards and things that he's doing in his career. If we had a sick kiddo, who's shutting down? Is the OR closing for the day or is the pharmacy closing for the day? And so we both agreed it just didn't make sense to turn back to going into pharmacy. Remote work, it was pre-pandemic, remote work for pharmacies, it was very limited. Plus, I have a bachelor's in pharmacy. I did not go for my doctorate. And I did not do a residency in pharmacy. So a lot of the clinical work was kind of limited for people that do residencies. So what I would be doing is going back into a retail setting, and that just didn't fit with the kids and providing them the stability and the schedule and the routine that they were used to. So I started looking into integrative wellness and nutrition. A friend of mine from pharmacy school went to the Institute of Integrative Nutrition to get a health coaching certification. I loved all of her information on Facebook and started asking her, like, how did you do this? What was your route? And I became obsessed with different dietary theories and different aspects of holistic nutrition, not just what you put in your mouth, but also how you feed your soul, how you rest, how you mitigate stress. And so in diving into IIN, there were so many great lectures, there were so many great discussions, and I really loved it. I found out that the program wasn't accredited by the National Board of Health and Wellness Coaches. And so if there's ever a time that health coaches can begin to bill insurance companies for their services, we will probably need a licensed certification with some sort of board standard. And that's the National Board of Health and Wellness Coaches and their exam process. So I found out that I needed to go to an accredited program. So I found the Integrative Women's Health Institute. It's an accredited program with the National Board of Health and Wellness Coaches. It was women's health. I was getting into, it was like pandemic time. I was turning 40. My hormones were all over the place. And so it was actually it was just wonderful to acknowledge that women are an ignored part of medicine and we are a different gender. Our hormones are different. The way we approach life is different. The way we approach every day is different. And so getting into women's health at that time was like, oh my gosh, I found it. I found what I can do. And so I started to connect with clients, with women about what's going on in their health, understanding that what during pharmacy school might have been tagged as woo-woo or fake medicine is actually really very helpful. Getting to the root cause of things and trying to prevent diseases and cut them off at the headway started to really make sense for me. So that is a very long story, but that is kind of how it came to be. Menopause and perimenopause education, connecting with menopause care providers. Then I was like really hitting my stride, right? Like these are things that light my fire. I'm passionate about advocating. I'm passionate about women advocating for their own health, and we need education first. There's a lot of postpartum education. There's a lot of pregnancy education. There's a lot of puberty and period education that happens in our lives. And then as soon as we've reached the end of our reproductive years, it's like nobody cares about telling us anything that's going on with our bodies, when in fact our brains are rewiring. Say that 10 times fast. Our hormones are ceasing production, which is affecting, body parts have estrogen receptors all over them. And so just trying to get into the why and the how and how to prevent some of the issues that women are facing, how to have them understand it. There's a lot of taboo topics I like to get into. So that is what inspired me, really, is my own story of being brushed aside, being told my labs are fine, there's nothing wrong with me, and feeling like it's crazy making. Gaslighting in my life was strong. And so I just needed to be able to get some clarity. So That was question number one. Sorry, that took like a million minutes. So I'm going to try to keep this short, but I feel like I just like to ramble. So my second question was, can pharmacists really play a bigger role in menopause care? Yeah. There's a lot of talk on message boards and board of pharmacy sites that we are discussing pharmacists as mid-levels or our pharmacist care practitioners, giving pharmacists the opportunity to prescribe certain medications given certain disease states and certain certifications and training, I think will go a tremendous way to help cut the doctor shortage. You have such a need for general practitioners, family doctors, primary care physicians, and what they're putting out from medical school isn't meeting the need of the country. And after COVID, especially when we lost a huge percentage of healthcare to burnout and career pivots, now is the time more than ever to accept and understand that pharmacists have the education and the training to, in collaboration with care providers, offer an opportunity to treat patients for certain disease states. Now, menopause isn't specifically a disease, but I do think that menopause care, treating for hormone deficiency in menopause when estrogen is no longer produced and progesterone is no longer produced in the ovaries, I think that we can be educated for this and absolutely help provide care. My dream job is to create a collaborative practice agreement or a consulting, a service agreement with physicians to be able to monitor patients, talk with patients about their lives, what's going on, what their medications are, work through medication interactions or adverse reactions or medications that are too high or too low in dosing. Also being able to talk with patients about their care plans that are holistic, including nutrition, moving your body, prioritizing sleep, having a good sleep hygiene routine most days of the week, mitigating stress, making sure that you're connected to a community. What does your lifestyle look like? What does your career look like? What do your relationships look like? Those are all part of thriving in midlife. And so I think that if I could create a dream job for myself, that would be it. Now, do pharmacists have education in menopause? Nope. Not unless they're specifically seeking it out. I'm a member of the Menopause Society. I am reading currently the Menopause Practice Clinician's Guide, 6th edition. Riveting stuff. There are symposiums and, annual conferences. There's continuing education you can specifically do. But I also think that pharmacists need to have a mandated continuing education for perimenopause and menopause guidelines and practices using the American Urological Association, American Urology Association's guidelines that just came out on genitourinary syndrome of menopause, going through the Menopause Society hormone therapy statement and the non-hormone therapy statement for the treatment of menopause. There's an osteoporosis guide on the Menopause Society. There's so many position statements of boards of medicine that have been researched and studied and ready to go for people to educate themselves. So if I go to my pharmacy licensing renewal website, I will see that I have to do a HIPAA or Medicare Part B required continuing education. I have to do a law required education. I have to do, when I became a licensed pharmacist in the state of Oregon, I was required to do death with dignity continuing education. When I became a licensed pharmacist in the state of Washington, I had to do HIV and AIDS training. We've had to do gender-based training. So there's so many things that are required. Why are we not requiring menopause education? Because there are so many patients who finally get the prescriptions for hormone therapy that they've been begging for and pleading for and looking for doctors to fill. And they get to the pharmacy and the pharmacist is the stopgap because the pharmacists are uneducated and because the antiquated warnings that are showing up in your software that you have to manually override are freaking out the pharmacist because they don't know any better. Can a patient be on an estradiol patch and vaginal estrogen? That will be flagged in a pharmacy data bank in a computer when you're filling a prescription. Should pharmacists know the acceptability of that? Absolutely. Should there be collaborations between community pharmacists and practitioners that are prescribing hormone therapy so that we understand their protocols? Absolutely. Should not be this hard for women. They're already asking embarrassing questions and being asked embarrassing questions in a doctor's office to get these prescriptions. We should not be standing at a counter holding them back from the treatment that they need. Off my soapbox. Okay. Question number 3. Is it really okay to use hormone therapy? There's so much conflicting information. Okay. So, one of the things that makes menopause education and treatment so difficult is that it's such an individual-based medication. It is such an individualized treatment. So, the WHI study in the early 2000s came out saying that hormone therapy causes breast cancer, and it stopped that section of their study early. There was an article that was published, I think it was in Time magazine, about it. It caused such hysteria. Doctors stopped writing it, patients stopped taking it, and we didn't look at the validity or the source of information. So while it was a large study and there was an increased indication that there were breast cancer patients, the patients that were studied were 65 and older. Some of them were more than 10 years out of menopause. Many of them had comorbidities, already had diabetes, insulin resistance, heart issues. They were smokers. They were unhealthy. They were also using a conjugated equine estrogen and a progestin. Nowadays, we have beta estradiol, which is a bioidentical hormone, meaning the chemical compound of the estradiol that you take by tablet, cream, spray, patch is the exact same chemical structure as the hormone that is produced in your ovaries. Micronized progesterone is the same exact chemical structure as the progesterone that is created in your ovaries. So if you are taking micronized progesterone orally and you are using an estradiol patch or the spray or a cream, you are getting the exact same form of hormones that your body already produces. There's a difference in that. They also found that oral estrogens can increase your risk of stroke because they can cause blood clots. They have not found that with transdermal estrogen. So that bypasses metabolism in a way that decreases your risk of blood clots. Also, if you start hormone therapy within 10 years of your last period, you will not have the cardiovascular risks that you are seeing in the WHI study. A lot of times, a lack of estrogen causes a hardening of your arteries. If you go back and you listen to my episode back in February with Dr. Morgan, she explains why estrogen is important to your cardiovascular system. And you can understand that if you haven't had estrogen in your body for 10 years, your arteries have already started to harden, and then adding estrogen can cause a problem. Those are the times that it is not indicated. Certain forms of breast cancer, it is contraindicated to prescribe estrogen therapy in those patients. But there's a very small amount of patients that hormone therapy is contraindicated for. So the key is personalization and finding a prescriber who understands this, understanding that even patients with breast cancer have been able to use vaginal estrogen to treat the genitourinary syndrome of menopause, meaning vaginal dryness and increased UTIs and thinning of tissues. There's so many things that vaginal estrogen helps with if you're seeing any of those symptoms. And even women that have had breast cancer can use vaginal estrogen. So a lot of research is being done. A lot of research is coming out. We're finding new answers. So I would say the most important thing is to have a menopause educated practitioner have a one-on-one conversation with you about your personal safety and efficacy of hormone therapy. If you're navigating the maze of perimenopause and wondering, is this normal? You're not alone. My free guide, Menopause Science and Symptoms, breaks down what's happening in your body and why. It's your roadmap to understanding the changes and embracing this phase with confidence. Download it now at missvictoriabyrd.com/free guides and take the first step toward empowered wellness. You'll also find the link in our show notes below. Be sure to sign up and grab that free guide. One of the other questions that I got was, how do you stay motivated with strength training during recovery? So I had back surgery and I could not exercise for months. I had surgery in January. I played it very safe and did not really do anything until mid-May because we were going to Disney World for May the 4th that year. And I didn't want to risk injuring myself before that because I knew, anybody, you talk about Disney World, you're talking about 5 to 10 miles of walking a day. Easy. And so I didn't want to put anything at risk in my recovery. So I followed all my restrictions. And the way that I stayed motivated to strength train was that I knew that muscle has memory. It will come back eventually. Starting slow was the easiest thing for me, but I will say I have not had a linear progression with strength training. I've had other injuries. I hurt my foot. I fell downstairs and probably tore ligaments in my foot. It took almost a year for my foot to recover and be at a place where I could work out the way I used to. I herniated 2 discs in my neck last year around this time. And I was looking at a potential of surgery, but we said, let's just give it some time because sometimes these things can correct themselves. And luckily I avoided surgery, but I had to really take it easy. And so for me, I don't have this history of years and years and years of being athletic. I wasn't a sporty girl in high school. I cheered in 4th grade, but I hated running. We didn't have strength training back then as an option for a PE class that I could take. And I didn't really even get into working out until Abby was 3. And I started going to the gym and doing the Les Mills body pump. And knowing what I know now about body pump, that was not causing muscle fatigue. That was a cardio workout. It was a great calorie burn, but it certainly was not helping me grow muscle. So just recently in my 40s did I discover the importance of strength training, and that's when I started hurting myself. So I think knowing that you can always get back to it, knowing that if you have to take time off for an injury or life is hard. I haven't really honestly worked out at a consistent pace since February. I did 6 weeks of 5-day-a-week strength training from January to mid-February. And it was great. I was seeing great strength gains. I was seeing muscle definition. I had energy. I had strength. And my life hit a brick wall. And I haven't really worked out consistently since then. So my life altered in a way that first I felt like I had quicksand under my feet. And now that I'm finally starting to feel like the ground is more concrete, my day is crazy and I'm spending a lot of time driving everywhere. So I haven't made it a priority yet, honestly. And I know the importance of it way more than I did 5 years ago. And I know that I need to maintain my muscle mass. I've lost a lot of weight and I've looked, and about 2 to 3 pounds of the 20 I've lost have been muscle, which makes me angry because it's so hard to build muscle. But that's just the way life is right now. So I keep my walking up, I keep my step count up, and I just try to focus on the things I can do. So motivated isn't really the answer because I'm never motivated to exercise. I think more of it is disciplined and determined and prioritizing my own health. And so that's what I say to women. You're never going to be motivated to work out. And if you are, good for you. But 9 times out of 10, you're talking yourself into doing it. A lot of questions that I get from women these days are about brain health and the anxiety. And so the mental health and the brain health. So brain fog. the word finding, the like, oh my gosh, what is that? And you're like sitting there looking at something and you know exactly what it is. Like you could be looking at this and you're like, what is, I know what that is. Can you hand me and you're staring at it and you just can't even think of the word. And it's something like fork. That is standard. Leaving stoves on, leaving curling irons plugged in, all the things we've been worried about all these years, they actually happen. Putting your keys in the fridge, done that. Walked into a room and not remembered why you're there. I can't even count how many times. And a lot of times that has to do with your exhaustion, having more on your plate than you should, but also just your brain is rewiring itself. I highly recommend Dr. Mosconi's books. She has the XX brain and the menopause brain, and both of those are amazing if you're interested in women's brain health. Our brains are different. Our brains rely on estrogen. When our estrogen in perimenopause is jumping through the roof, our brains don't know how to handle it. And when our estrogen is in the tank, our brains don't know how to handle it. And the variability is so, our bodies like symbiosis. They like everything to be calm and even and not changing. And those extreme fluctuations just really mess with your brain wiring. And so it's not just that you're tired, that you're stressed, that you have too much on your plate, that you have the mental load of the whole house on your brain. You're also dealing with your hormone fluctuations. So I really think that digging into those books, understanding how the brain works, and the Menopause Brain book is for everyone. It's not a clinician's guide. So you'll get some big words, but you're not going to get so overwhelmed with science and medical terminology that you can't understand the book and get something from it. So I highly recommend that book. Okay. So I'm going to take one last question because we're hitting about 26 minutes. A lot of women have issues with weight loss and fat loss and the midsection fluff. And they have asked me, how do you manage it? How do you lose it? How do you keep it off? And I could even have a whole conversation with you guys about this. So I'll try to keep it brief so that I'm not rambling unto excess. But there are many approaches to nutrition for midlife women. And all of them require an individualized look, right? So 70% of us have had some form of disordered eating in our life. Thank you, Mary Claire Magazine. Oh, sorry. I shouldn't throw out Mary Claire Magazine. That's just what I read. That, Teen Vogue, Teen Cosmo, Teen Beat, Teen Bop, all the teen magazines, plus also the television shows and the runway models. I mean, we grew up in the era of Kate Moss. Need I say more? We grew up in the time of cardio is king and little pink weights. And so, skinny is the new skinny. Now we've gotten to the point where strong is the new skinny, and you have the Dove ads, and you have body positivity, and you have women of all shapes and sizes on television and in print ads. And even though those are great, it still doesn't change the issues that we have around food. So a lot of times I'll talk to women and try to find out where they are in their life. Like, what is your bandwidth? What is on your plate? What are you capable of doing? Some women say, absolutely, under no circumstances do I want to track my macros. Okay. If I tell you that the most effective way to really monitor your food intake and your protein intake and making sure you have the right profile of fats, carbs, and protein, and that you're fueling your body if you're trying to gain muscle is to macro track, it doesn't matter if you don't want to do it, because resisting is going to lead to failure. And so if you're not interested in scaling food and tracking food and having a macronutrient profile of 40% carbs, 30% protein, 30% fats, or whatever the percentage would be based on your lifestyle, then we talk about maybe the plate method. Maybe we talk about intuitive eating. Maybe we talk about just focusing on how much protein you get a day, eating the same thing for lunch every day during the week, or eating the same breakfast many times a week. Those are some things that you can talk about. The midsection fluff is because your hormones are shifting. Your body is beginning to store fat there. Estrogen is produced in fat. It's not estradiol, but there is an estrogen that is produced in fat. So sometimes your body is protecting itself by trying to produce estrogen for all the receptors in your brain and your muscles and your bones and your organs. And so that midsection fluff is a protective mechanism. Also, you are at an increased risk of fracture as you age. If you are osteopenic, if you're not strength training, if you don't have dense bones that are bendable and not breakable, if you fall and you break your hip, you have a 50% chance of being dead within a year. Yeah, like scary. And so our bodies are insulating ourselves. So there's something to be said about having a little bit of fluff when you're older. But we're so heck bent on being as skinny as possible that we don't think about that. We're more impressed by body image than we are with body longevity and health. So there's actually studies that show that as you age, having an increased body fat percentage is good for you. So talking about mindset, getting your mindset right about, everyone wants to look and feel their best. But why are we so determined to stay looking like we're 25? Is it because we feel irrelevant and invisible? Is it because once we've aged out of our reproductive years, we feel like we're not valued? These are things that society needs to fix. We don't need to fix this with our diet. I do think that women don't understand the nutrient dense versus nutrient void foods. And we eat a lot of calorie dense, nutrient void foods that trigger more hunger because our bodies need things to survive. And so if we're not eating what we need to fuel our body, we are going to eat more of things that we don't need. I also think that understanding portion control is huge. I mean, even just portion sizes, really. A portion size of peanut butter is 1 to 2 tablespoons. I don't think anybody really ever measures 1 to 2 tablespoons of peanut butter. I mean, I could stick a spoon in a peanut butter jar and eat it by itself, and that's 3 tablespoons. And nobody thinks about this. High fat foods are more calorically dense than lower fat foods. Refined carbs and sugars have a strong reaction to the body, an impression on the body. And so taking a look at why you're eating and what you're eating and when you're eating is also something that I talk with clients about. Sometimes it's as simple as take pictures of what you eat every time and put it in a food journal for me so I can see what you're eating. Sometimes people actually make better choices when they have somebody checking their work. But also, it's a good record of like, oh, wow. Okay, I didn't think I ate that much today, but I had breakfast and then I had a salad and then I had a bag of Twizzlers and a candy bar and a Coke and then I had dinner. And then I had dessert. We went out to eat, or we went to a movie afterward and I had popcorn and a Coke. These things all add up, and we're more sedentary now than we were because we're exhausted. And so you have exhaustion added in, and you have cortisol spiking, which helps your body retain fat in a panic state. Because when we are back in our caveman days and our cortisol levels were high, we were storing fat. A lot of times we didn't know we were going to eat again. And so you store the fat. And that's another problem. So it's so much more complex than just calories in, calories out. It's really taking a look at each individual woman and working with them over a long period of time. You're not going to drop 20 pounds in 6 weeks unless it's unhealthy and it's not sustainable. And if you're not doing sustainable life choices where you're slowly losing weight or losing fat, then you're going to go on these crash yo-yo diets. And if you say to yourself, oh my gosh, I did keto 3 years ago and it totally worked. Well, if it worked, why are you doing it again? Or why are you looking for something new? So those are some questions that we talk about. A lot of times with clients, we talk about stress, and just talking about stress reduction, you see a weight loss or a fat loss. It's just so complex. And it makes me angry when people say it's just calories in, calories out. And it makes me angry when women are sold another cookie cutter program with some promise to be small. And so working on your mindset, working on your goals, your own personal goals. Not everybody wants to have six packs, abs by spring break. Some women just want to be active. Some women are trying to live till they're 90 and not be in a nursing home. Some women want biceps and they want strong legs and they want muscle definition. There's nothing wrong with it. We need to stop judging each other for why we do what we do. But I think that taking an individualized approach, having support and accountability, those are the things that you really need for success to get any kind of fat loss or diet under control in menopause. So we're about 35 minutes in. This is going to be too long if I keep answering all the questions. I'll have to do another AMA. In the meantime, if you do have questions for me, send them to me. There's an email in the podcast notes. Check out my free guides. Those are great resources. I offer one-on-one coaching for a small number of clients. So if you're interested in that, I don't have a lot of availability, but we can chat. And until next time, stay curious, do your own research, advocate for your own health, find a new doctor if the one you have doesn't suit you or you've outgrown that doctor. It's okay. And I'm excited to do this again next time. Thank you for listening to this episode of Women Mastering Midlife. If something you heard today resonated, I'd be so grateful if you'd share it with a friend who might need a little extra support on her midlife journey. Remember, small changes can make a big difference, and you don't have to navigate this transition alone. We will be back next week with more expert guidance and compassionate conversations to help empower you to master midlife on your terms. Until then, you can find us on Instagram at Women Mastering Midlife, or come connect with me directly at Miss Victoria Byrd. And you're looking for deeper connection and support, be sure to join us in the Women Mastering Midlife community. We'd love to continue the conversation with you there. If you've enjoyed this episode, please rate and review this podcast. It helps us reach more amazing women mastering midlife just like you. You'll find all the links from today's episode and ways to connect in the show notes below. See you next time.